Thank you for that very generous introduction. I've actually never added up all that stuff. It's sort of, you did the research. And then when you mentioned the article about how current policies could make things worse, I just felt this compulsion come over me that I need to write a sequel. So thank you very much. I'm really pleased to be here. I have to tell you, this is the first time I've ever been to Syracuse, so I'm really grateful to have the opportunity, not just to be able to say I've been to Syracuse, but get professionally, as I'll talk about during my remarks. I think there's a lot going on here in Syracuse that I can really relate to because of my own interests, and a lot of very impressive initiatives that I'm hearing about that I think are really at the heart of what the whole country needs to be doing in both urban and rural settings. So this morning we've had sort of a theme that's focused a lot on the opioid crisis and some of the issues surrounding that. I'm going to interrupt that for a few minutes in my talk. I'm sort of going to go back up to the 30,000-foot view to step back more broadly on the topic of the conference, which is society and health. So focusing more broadly on health across its many different forms and how conditions in our society and our environment are shaping that. But you're going to get back to the opioid thing before I'm done with this talk, so we can't avoid it. But also, I'm going to go to the 30,000-foot view in terms of geography and step back and actually begin with one of the items that was just mentioned, which is how the United States compares to other countries, then focus on how we look as in the United States across our states, and then go down to county, census tract, and neighborhood. All of that, I think, is very important when we think about the relationship between society and health, because it's really complicated and it's multi-level. So we have to think about all the different ways and levels in which that influence occurs. Let me start by dealing with the common misconception that health is about health care, and that since we have very advanced healthcare centers like this one and many others around the country, where we have excellent doctors in the United States, the best technology, the most innovative biomedical science, and so forth, that number one, we have the best healthcare system in the world, and that we have the best health in the world. This is like what the common rhetoric is in society. And most of you probably know that neither of those things are true. Our healthcare system is actually challenged in ways that other countries don't confront. But also, our health is not very good. And one of the opportunities that I had was to try to understand why that is. The next slide you already saw, which was the county health rankings model that Dr. Gupta put up. But this previous one is a more complex one. It's a little too busy to be used for general audiences. But this is the World Health Organization's conceptual model for all the factors that affect health. And I don't want to dwell on it too much, other than to say that when I talk to my clinical colleagues, I know they can't see all the letters from the back of the auditorium, but I just tell them there's this box down here called the health system. And that, getting back to the point Dr. Gupta made, is healthcare is important. I view it as one of those things that's necessary but insufficient. We have to have a good healthcare system, both for the prevention and treatment of diseases, but this alone is not what's driving our health. And so we need to think broadly about all those other factors. It says 20% in this model. Other studies say 10%, 15%. Somewhere in that window is the kind of impact that health has. So a few years ago, I had the opportunity to chair a National Research Council panel that produced this report called Shorter Lives, Poorer Health, in which we were asked to compare the health of Americans with 16 other high-income countries. You can see the list here. And they're all large, established economies, democratic countries, some of them very similar to our own. And what we found was, and we went into this sort of expecting that on some measures we were going to do worse than in other countries. It was well known at that point that U.S. life expectancy did not compete well with other high-income countries. In fact, here's the data that we showed, and you can see that the U.S. is at the bottom for males and second to the bottom for females. But what really blew us away was what happened when we did a more detailed analysis of health metrics in comparisons between the U.S. and the other countries on specific causes of death and causes of illness. And again, I don't expect you to be able to read the print there, but I can just tell you that what's listed in the left-hand column are different categories of disease, like cardiovascular disease and so forth. And the upper part of the table are all the conditions where U.S. Mortality rates are higher than the OECD average for other countries. And the short list at the bottom are the ones where the U.S. has similar mortality or better. And the good news down there is that in terms of cancer mortality and so forth, Americans have better mortality rates, there's lower mortality rates than in other countries. Suicide, about the same. But the larger set of conditions up above it, not so much. The U.S. is doing worse, higher mortality rates. And the problem our panel had when we looked at that was, how do you explain that? You couldn't find one common denominator. You couldn't say, well, it's obesity, and that's why all these different why U.S. has a health disadvantage around that, or it's guns, or it's any other particular issue, because they're so diverse that it cut across many different disease categories and sources. The statistics were stunning, especially when you look at the trends over time. So this slide is showing you the red dots are the United States, the gray dots are the other countries, and it's going back to 1980. And so what you basically see is that over time, both for males and females, we've been falling to the bottom of the pack in terms of how we compare in terms of life expectancy. We wondered whether that was due to a particular age group having a problem, like is it infant mortality that's causing this? Is it midlife diabetes? Is it something around end-of-life care? And actually what we found is that in every age group, from birth all the way till about age 75, the U.S. ranks at the bottom. And so, we say sort of facetiously, if you can make it to age 75, you're in great shape to be in the United States, but otherwise not a good situation. This is probably the most stunning of our slides when we were looking at this. This is showing the probability of surviving to age 50. So for the males, what you see, and I'm going to walk over here again to show you, is that beginning in 1980, we're already at the bottom of the pack, and then the situation continues to worsen. But for females, they start out at the bottom of the pack, and then look what happens here. So completely going off the chart. So basically what that slide is saying is that the probability of a woman surviving to age 50 is lowest if it's an American woman. This is something that I don't think the public actually knows. A very similar finding with survival to age 5. The probability that a child will reach age 5 is lowest if it's an American child. So this is not widely known. So that's cross-national. Now let's sort of turn inward and look domestically in the United States. We can map out various health outcomes by state. This particular one is life expectancy. We just released a report a few months ago called The Health of the States, where we looked at 39 different health outcomes by state. And you see typical geographic patterns here. The usual story here is that the Deep South seems to have the poorest health. In our report, we found that that's not always true, depending on which health outcome you're looking at. Suicides, for example, are highest in the mountain states and so forth. Then we can take it down to a more granular level. So this is a study that we did in California where we looked at life expectancy by census tract. And as you start zooming in geographically on the places we live, you start seeing more diversity. So giving out, if I back up and you look at how California looks there in that life expectancy map, the state average looks fine. But then when you start zooming in, you start seeing that granularity that, well, it's not so simple, is it? And then in the inset, you can see LA, and Dr. Gupta probably knows this from clinical experience, that there's a very big diversity in health outcomes. We started popularizing these maps that are showing, and these are meant for a general audience, for the media, for policymakers, so it's meant to be engaging in a way that a typical geospatial map that you'd use in a peer-reviewed article would not. to sort of call out these differences in life expectancy. This one was done for Metro Washington. It was Washington Metro map showing how at different stops there would be differences in life expectancy. We produced this a few years ago, back when we believed that people in Washington, D.C. were interested in data. So we'll probably retire that one. But this phenomenon exists everywhere. So in all our major cities, you see very big differences in life expectancy. I didn't have a lot of time to prepare for this talk, but thankfully Dr. Gupta's agency had some good data on the website there to illustrate, what you already know, is that life expectancy in this region as well also is very different. This is a map we produced for Chicago. You could do the same thing here in Syracuse, and I could predict what the answers are going to be. When you analyze life expectancy by census tract, you see in most American cities differences of 10, 15, 20 years, often for census tracts that are only a few miles apart. So why the difference? When we do show these maps to the media and other policymakers, the question actually comes up, well, why is that? And this is where we get into this whole issue of social determinants of health. Yes, healthcare matters, so some of that difference might be related to differences in access to healthcare, whether it's lack of health insurance or literally a lack of access to providers or hospitals. But other factors matter greatly. Probably the most important is up there at the top, which is socioeconomic status, education, income, wealth, occupation, employment, and so forth, we know are hugely important. Dr. Montez and I are going to be doing a session tomorrow where we'll talk more about that. But other things in our built environment are important. Housing, we know, has an important link to health. Access to foods, the ability to be physically active. So we know that those health behaviors that were talked about in the earlier presentations drive chronic disease rates, so smoking, physical inactivity, poor diet, and so forth. But you can't be physically active if you are in a place where you can't be physically active. I, as a family physician, if I saw a parent with an obese child, the guidelines say that I'm supposed to counsel the mom for Johnny to go out and exercise or play outside for 30 minutes a day. But if Johnny lives in a place where you're at risk of shootings, or there's no park and there's no place to exercise, no way to get on your bike, then obviously that impedes physical activity. We'll talk more about this in a minute, but other aspects of urban design, such as where toxic pollutants are emitted, where the bus depots are located, how highways are designed, and so forth, also affect our health. I have in there access to doctors and so forth, not meaning to minimize it, but to say it's part of a portfolio of things that shape our health. Transportation and segregation I'm going to get into in just a minute. This is typically how Americans think of how to improve health, is to bring in the high-tech intensive care, trauma services, and expert doctors to help with these problems. But healthcare systems now, especially in the era of health reform, where healthcare systems are responsible for population health and are held accountable for that, are recognizing that they really have to think outside the clinic, that there's a certain amount that you can do. And I think Dr. Gupta put it well in terms of when people leave the ward or when they leave the doctor's office. I mean, as a physician, you're constantly frustrated by discharge. You admit somebody with bad congestive heart failure, you tune them up, you get them all stabilized, and then you send them home and they are a readmission. They're back in a week or so, or 10 days, what are euphemistically called a bounce back. And as a young doctor, I just found that frustrating. But as I gotten older, I realized it makes perfect sense, because you're sending them right back into the community conditions that got them sick in the first place. And unless you're going to address that, yeah, they're going to be back. The diuretic you're prescribing is not going to take away all of the other problems that they're encountering. So we know that we therefore need to think about the factors in our communities that affect this. Typically, people in public health go right away to this issue, the built environment. I was already talking about green space and bicycle paths and so forth. We also talk about food deserts. at breakfast this morning, I heard that the first supermarket was being opened in 50 years? Did I get that right? Okay. So, I mean, those kinds of environmental factors matter greatly. Not only the lack of access to places that sell healthy foods, but the the overpopulation of fast food restaurants or corner stores or bodegas that sell unhealthy foods, or liquor stores and so forth, that are all part of the environment that affects our food. But now we realize that it goes beyond this. It's policies that society doesn't normally think of as health policies. So decisions that are made about transportation and where the bus stops are going to be and where the train's going to stop and so forth, zoning decisions that determine where things are in proximity to where people live, tax policy, what the taxes are going to be on cigarettes and so forth. Housing policy, is there mixed income housing that gives people some stability? Studies show that unstable housing is one of the biggest predictors of health outcomes. And I put et cetera on this slide because you can fill it out. I mean, there's much more that we could list here, but the term health in all policies has come to advocate the idea that we should get policymakers to think about health in decisions that they wouldn't have traditionally thought of as being relevant. So it's not Medicaid, it's not issues about physician reimbursement or things that they instinctively think about as the health policies that they need to be deciding on, but for folks who are working in the housing agencies or folks like the Lieutenant Governor that were here to think about what are the health implications of some of those choices in a more consistent way. The problem that we have with this, though, is we live in a world of silos. So I'm sure it's true in Albany, as it is in most state capitals, that there's a particular committee in the legislature that feels like that issue is not part of their jurisdiction. There are sections of your newspaper that are about health, and then you turn the page and you get to the economy, and people don't realize, well, that economy article is actually more important to their health than what's reported in the health section. So those silos are sort of baked into our society, but we're actually not going to get very far in achieving transformative change in health or many of the other conditions that affect our well-being without getting across those silos, without building bridges. So that the theme of cross-sector collaboration is something I'll come back to in a second. I direct a center at my university, which is really not really meant to be named after your conference, but it's the Center on Society and Health is literally the name of it. But one of our main goals is we call connecting the dots, is helping the people in these different sectors see each other and recognize the interconnections between these issues and how there's a common agenda, common cause in terms of moving forward with this. And I'll elaborate a bit more on this in a second. I mentioned earlier that education and income are big factors in shaping our health. And just to give you some quick examples, and I could spend the whole time just showing bar charts to you, but basically there's a gradient that is well established where you can see in this particular example it's graphing self-reported health, but I could put up heart disease, asthma, any number of things, you'd see the same basic chart. That people with lower educational attainments, not having graduated from high school, tend to have much poorer health outcomes than people with more advanced education. Here I've got a list of different diseases that if those of you who are clinicians will recognize that this pretty much occupies most of your day treating these kinds of problems. But also if you're an employer, you realize that these are major drivers of healthcare costs and affect the productivity of your workers. And if you're an insurer, you know that this is affecting what you're paying out in terms of costs. But what you'll notice when you look at the rows of data is this gradient, that for most of them you see much higher rates of disease associated with a poor education. Why is that? Well, it's complicated. The relationship between education and health involves multiple pathways. This is a graphic we developed to try to help sort it out. Part of what you're seeing there is that education gives you resources that in a knowledge economy that can help with your health. For example, it gives you the kind of income so you can live in a nice neighborhood where you have access to the resources we talked about. It has social and psychological benefits. People who are more educated tend to have healthier behaviors, so they're less likely to smoke and so forth. And all of those things help to improve your health, but there's a pathway going in the other direction, what is technically called reverse causality, where you have the notion that people who are in better health are more likely to succeed in school. So picture the child with asthma or ADHD who is going to do less well in schooling. But the thing that probably matters the most, at least to me, is that green thing at the bottom, the contextual factors. The relationships we see between education and health or income and health often have a lot to do with the conditions that people are living in. So the best example I can give for you is picture a child growing up in a rough area of Syracuse where there's a lot of poverty, there may be a lot of violence, a lot of drug use, and so forth. Those children are being exposed to what we call adverse childhood experiences, or ACEs, and we know from the literature that that's bad for them. Physically, it also increases their risk of developing unhealthy behaviors like smoking and drug use and other risky behaviors. Studies have shown also that it's a risk factor for developing chronic diseases later in their lives. But getting back to early childhood, if those kids are exposed to that kind of toxic stress and trauma, then it makes sense that their health is going to be affected for the various reasons we just mentioned. Oh, by the way, also they're not going to do well in school. So you end up with this correlation between education and health that really is about the root cause being that experience they had growing up. And so if we want to break down that unhealthy relationship, we have to deal with those environmental conditions. I can keep going with the bar charts. I'm flipping from education to income here, okay? We're still looking at self-reported health, and you can see the same gradient, less income, poorer physical health. But it makes sense, it's not just physical health, it would also be psychological well-being. People obviously are more likely to have anxiety, stress, hopelessness if they're living under conditions where they can't make ends meet, and that makes a lot of sense. But you know, while epidemiologists and others have focused for years on the important role of socioeconomic status, education, income, like we just talked about, much more awareness these days about the role of place. So whatever degree you have or whatever money you have in your wallet doesn't completely buy you better health if you're living in a place that exposes you to health threats also. And so we increasingly are recognizing that although I have the education and income up there on the top, the other things we mentioned are also hugely important. So no matter how rich you are or what degree you've got on the wall, you're still breathing the air. You're still going to get hit by the bullet if you're in an environment that it is unhealthy. I want to turn now to the subject of race. This is the Time magazine cover when the riots were happening in Baltimore. I think the experience of health and its relationship to racial and ethnic disparities is really part of a much bigger story about the adverse experiences that occur by race. And I'm going to be talking to you about the experiences of people of color, but at the end I want to come back to talk about another racial group that has gotten into the news lately. But let's talk first about populations of color. And I say this is my first visit to Syracuse, so I'm pretty ignorant, and I had to spend some time studying a little bit about Syracuse before coming here and reading a little bit about the history. And what I was fascinated by, frankly, in reading about Syracuse is how many themes that we talk about in the field about the challenges of urban America are portrayed in such a classic way here in Syracuse. That's not always true in every city. You can go to Houston or other places. There's parts of it that you can see playing out there, but it's not exactly the combination that you have here in Syracuse. So one thing that sort of jumped out right away is it's a very segregated city. There are sharp divisions in terms of racial and ethnic distribution. And we know from work that's been done by sociologists and others for many years now that this doesn't happen by accident. There's a history that sort of leads to this. I found this information, and it was repeated to me after I got here, that this not great statistic for Syracuse, that it has the highest concentration of poverty among African Americans of the 100 largest cities in the country. And when we see this, society, at least in its narrow-minded view, sometimes thinks of this as the choice the affected population has made to not be productive or not pursue the economic opportunities that America offers, but actually it has a lot to do with the history of what happened before. So this is, I'm going to proceed into this acknowledging my ignorance, but just telling you what I learned in reading about Syracuse. So first I started out reading about the 15th Ward. And descriptions from people who are in their 80s now describing what it was like back in the day when they were growing up. My understanding, and there's a 15th Ward in most major cities in this country, a story like this, that there was once a vibrant neighborhood with strong social capital, the term used for people with strong ties, where neighbors, there was a fabric of community where people had your back, and that the moms who saw kids misbehaving, it didn't have to be their kid. They would get them by the ear and bring them inside and get them to settle down. That kind of world existed in the 15th Ward. And then along came redlining, as it did in many major cities around the country. You all familiar with redlining? Okay, put your hand up if you are. Okay, so some of you are not, so I'll just quickly mention that during the Roosevelt administration, there was a move to promote the construction of new housing, to promote home ownership. It was also a strategy for creating job opportunities for the construction industry and so forth. But the home loan folks who were responsible for deciding how to give out loans produced maps like these for a lot of major cities. And the red zones were the ones that were least likely to be given loans. Those tended to be black and Jewish communities where they weren't really too interested in giving out loans to those folks. And those neighborhoods that were redlined, you can actually go to a website now and download these redline maps for any major city. You put them up next to current modern day maps of, I don't care whether you're talking about health problems, crime, poverty, education, et cetera, so forth. They're often very similar. I won't say they're mirror images, but they're often very similar. I got a lot of my information from this article. I don't know how many of you have read it, but it was very telling, which was sent to me by a faculty member here. I can't remember exactly who it was, but it tells the story in a very poignant way. And I often talk when I give talks to students and so forth about social epidemiology, discuss the role not only of segregation in the form of racism and discrimination, but also how urban design, the way cities were built, played a role in isolating neighborhoods and segregating them. Because typically, what I explain to them is that a highway or train line or whatever was put in that walled off one neighborhood from another and socially isolated it from the economy, from the labor market, and so forth. In this story, if I've got it right, it wasn't that they walled off the neighborhood, they put the highway right through the middle of it, like a stake through the heart. I mean, this is, I was told 1956, the state passed a law to fund the building of I-81 right through the middle of the 15th Ward. Did I get that right? Okay. So in their wisdom, and basically this contrast I think was very telling when I saw it, of the way urban design can have consequences. And it's a case where the physical infrastructure of the city actually cuts off the economy and the social capital that we know are drivers of health. I read about Wilson Park and the way it used to be back in the day. And my understanding is that this highway was built right over Wilson Park. And so it creates segregation. It's a physical representation of segregation. Here I've put the redlining map up against a more recent map of median household income. And to my eyes, I see the same thing I've typically seen in other cities where the areas of concentrated poverty are products of some of those older decisions. And I loved going back to look at those old black and white photos of what it used to be like in the 15th Ward and the kind of vibrancy and the stories that I was reading online from the narratives of people recalling the lifestyle at the time. I then got on Google Maps to see if Wilson Park even existed. And I found that it did, and I used Street View, and there I saw this image. Now, you all know this place, I don't. But what just jumped out at me as an outsider is there's the park and there's that highway. And it's just very, very poignant. So in my final minutes, I want to bring up recent events and talk about how when we think about race in America, we naturally go to the experiences of people of color, African Americans, Native Americans, the Hispanic, Latino communities, because these are populations that we know from both the experience and research are disproportionately impacted by these adverse socioeconomic conditions. Recent events, though, have made us more aware of the experience of disadvantaged whites, especially whites living in agricultural or rural areas of the country. This is data I found on the population distribution of rural New York, and the fact that you have this, large population of whites living in counties that face difficult economic challenges. And I thought this was relevant here because I know this medical center serves a large part of rural New York. And so the problems of rural America come to your doorstep along with the challenges of the inner city. David Kindig, who's one of the big experts in population health, just had an article in JAMA in which he took on this really delicate subject. This is a little bit of a hard thing to talk about, that whites obviously are a privileged class, but low-income whites or poorly educated whites still have significantly poorer health outcomes than more advantaged whites. And in sheer numbers, because they represent such a large population distribution, actually, into absolute magnitude, have more health inequity from a policymaker's perspective than minorities do. His way of wording it is shown there. It's still statistically a lower risk of mortality and premature death than people of color experience, but it's not trivial. And we saw politically the impact of this population in terms of shifting the direction of the presidential campaign and so forth, but from a health perspective, it sort of raised a red flag that they also need attention for the health experiences that they're having. I don't know how many of you caught the coverage in the past week of the new study by Case and Deaton. This is the two economists from Princeton University. They had published a study a couple of years ago that showed rising mortality rates among poorly educated whites, and they just came out with an update. It's causing a bit of a stir in my field because there's some real controversy about the methods that they used, and I won't get into the technical details unless you want to. But nonetheless, here's some of the images that are appearing in the news coverage about this study showing the increase in mortality among whites. But in particular, what you see is this division based on socioeconomic status, where you can see that it's the less educated whites that are experiencing an increase in stress-related conditions. So if you look over there at the x-axis, you see poisoning, suicide, alcohol-related liver mortality, in other words, cirrhosis. So now we're gently stepping back into the topic we were on before this morning. That you see in this population a dramatic increase in deaths from not just the opioid epidemic, but other related causes. In this particular slide, Case and Deaton draw a contrast with the other countries. So what you see on the left are France, Germany, UK, and so forth, with deaths per 100,000 decreasing, and non-Hispanic whites in America is the red line. And so you can see a very different pattern. I talked to colleagues in other countries, the British and so forth. They're not seeing this thing that we're seeing here in the United States. Denmark, I have a friend in Switzerland who works in the field. No, they're not seeing this there. There's a little bit of it happening in the UK, but nothing to the degree like we have. Opioid epidemic, they don't know what I'm talking about. They don't have that. This is an article from The Guardian, which is the British newspaper. And sometimes you have to have a distance across the Atlantic to sort of see what's going on, drawing a link between the economy and what may be going on. I don't need to show this slide. I think it was already shown. But I would put it in here to simply make the point that this topic is no stranger to you. Case and Deaton have coined this term deaths of despair. And I think it's worth stepping back. When we talk about the opioid epidemic, we tend to get so focused on the problem of narcotics and prescription opioids and the pathway to getting heroin and fentanyl and so forth, that it's important to understand that it is the most conspicuous feature of a larger problem. So those drug overdoses include not only opioids, but amphetamines, sedatives, and other drugs, cocaine, et cetera, are among the various drugs that are responsible for the overdoses. And there is this spike in drinking, dramatic increases in alcohol use, dramatic increases in our research on deaths from alcohol poisoning, which is basically binge drinking, among people starting in their 20s all the way up to middle age. Dramatic increases in suicides. And you'd think, well, maybe those suicides are just because people are in the drug problem and they're committing suicides with drugs. No, the number one form of suicide that's responsible for that dramatic increase is hanging. There are a series of symptoms that we're seeing in our society of people expressing this sense of despair. And so when we think about the solutions to the problem, we have to step back and go, why the despair? What are the root causes for that? And invariably, I mean, we don't have time to get into it, but invariably it takes us into a discussion of the economy, of the American dream getting dashed, and so forth. We are just completing a study now in California where we are looking at the causes of death that are responsible for this increase in mortality rates. And what we're seeing is that it goes far deeper than overdoses and suicides and drinking. As a doctor, when I started looking at the other causes of death that are spiking, I see clear connections. And you also see regional patterns. So I don't know how many of you know the geography of California here, but the area where we're seeing the problem the greatest are in these northern rural counties north of Sacramento and in the Central Valley of California, in the San Joaquin area and so forth. Those are the areas of the state where mortality rates are rising among whites. The coastal communities like LA, San Diego, San Francisco, you're not seeing it. It's in those areas. Well, the map on the left is showing you unemployment rates. I could show you other maps showing you the poverty rates. These areas of the Central Valley and the northern part of the state are areas where the population is experiencing very high poverty rates and poverty rates that are actually increasing due to the changes in the economy. You can imagine, I don't know what they are, but I'm sure you can just sort of sketch out the map for the counties here in New York that are the equivalent of the Central Valley and Northern California. Rural counties that are experiencing high or increasing poverty rates. And in those areas, what we're finding is increases not only in suicides, but in various complications, hepatitis C, hepatocellular cancer, liver cancer, because hepatitis C and other viral hepatitis are risk factors for liver cancer. We're seeing increases in deaths from aspiration pneumonia and a number of other conditions that we think are potentially linked to people overdosing or experiencing these other drug behaviors. Whenever you don't understand data, go for Doonesbury, because that helps a lot. Can those of you in the back read this? Because if not, I'll read it out loud for you. Okay, so you see an African-American man saying, "Nice day," and then someone off to the side says, "Easy for you to say," and the African-American says, "But not for you?" "No, my kind is dying off." And then you see there's a white friend of his sitting there. "Man, my peer group's sure getting hammered lately." "What peer group's that?" And the white guy says, "Middle-aged whites, the mortality rate soaring." By the way, this just came out. He did it after the Case and Deaton study. And the white guy says, "They're called deaths of despair from drugs, alcohol, suicide, driven by economic and social distress." Oddly, it doesn't seem to affect blacks or Latinos. "Nothing odd about it, man," the African American says. We've always lived distressed lives. We're used to it. So the white guy says, "So black privilege?" And the black guy says, "Absolutely, we're lucky that way." people are beginning, this is somewhat humorous, but at the same time, a potential hypothesis for what's going on here is that you have a population of middle-class whites that were protected for so much of our history from the kind of socioeconomic stresses that people of color have experienced for generations or centuries, who now have had that dream, that bubble bursted. There used to be a sense that if you got a job at Carrier or some other company, steel industry and so forth, you had a job for life. You could count on having enough of an income to get a house, put your kids through school, retire, and so forth. And that was the case for today, the parents and grandparents of today's middle-class whites, but they are not experiencing that now. So is that potentially an explanation for why we're seeing this escalation in frustration, depression, and deaths of despair? Hard to say. I'm out of time, so I'm going. Keep. I'll pick up the pace here. You have a hand up in the back.
Yes, just curious. Native American. We have our amalgamation. You've got the highest mortality rate and poorest health conditions of any group, yet I don't hear much overall from it.
Well, let me. Yeah, that's a gap worth pointing out, and I apologize for that. But let me build on your point. That study I showed in California. There are two population groups that are experiencing a rise in mortality rates. Whites, only in those counties that I showed you, in the Central Valley and the northern part of the state. The Native American data is showing this huge spike in mortality across the entire state that is so large that we actually have decided to take that on as a separate study to try to understand what the drivers are for that. I don't know whether you have the same data here in this state, whether the rates are climbing at the pace that we're seeing there. But
I actually just got a call from someone who helped with the medical force.
yeah. So I think it's a huge public health issue, and we need to unpack. We actually plan to do that in our work, what's driving that, because the distribution of diseases that may be driving that may or may not be the same as what we're seeing in the white population. Okay, I just want to close by talking a little bit about the importance of collaboration. So this is I'm not a good artist, so this is like my Charlie Brown tree. But if you think of well-being, so one of my colleagues, Jim Marks at the Robert Wood Johnson Foundation, has lately been saying people don't care about health. This is a guy, the vice president of the Robert Wood Johnson Foundation. People don't care about health, they want a good life. And health is important to having a good life. But really, if you think of that larger goal of well-being that we want as a community to have a better life, and you think of the branches in this tree as the different sectors that feed into well-being, health being one of them, but it's also good housing, safe communities, a clean environment, and other things you would add to it. We are recognizing that there is a shared interest in improving the opportunities for well-being that is shared across sectors. And once we identify those common incentives, we realize that we have partners in achieving this goal that no single sector can achieve on its own. So Upstate can decide that it wants to transform the health of Syracuse. It's not going to succeed if it doesn't have partnerships with the other sectors that are actually responsible for those conditions. Law enforcement can say, we're going to do something about this opioid problem. They're not going to succeed if they work alone. The public housing people can't solve the problem alone, but together they can. So we did this study a few years ago. We were trying to make the case for the importance of education, and we were using just our health lens. And we were saying, if you invest more money in education, the better health outcomes you're going to receive are going to save you so much money because you're going to have lower costs on Medicaid and you have a more productive workforce, and we're doing the math for that. But the fallacy in that, so that's basically just looking at this one link here. The fallacy of that is that improved education benefits many different sectors. So if you're going to do an econometric analysis of the return on investment of education, you've got to add up, you've got to do the math for all of those. And whereas the policymakers in Albany or elsewhere might not be impressed by your math if you're just looking at the healthcare savings, When you start adding in corrections, employment, tax revenue, social services, and all the other benefits that come from a more educated population, now you've got a much more compelling ROI. So this is just one example of where everyone benefits through that cross-sector collaboration. The other way is through collective impact initiatives, where communities sit down at the table, all the stakeholders coming together, the employers, the Chamber of Commerce, the various agencies and so forth, each bringing their particular expertise to the table, also bringing their data sets to the table, because they all have their own data, bringing it together and say, we're going to identify a set of objectives that we want to achieve here in Syracuse, Rochester, whatever the community is. These are our goals, and we're each going to work together toward achieving those goals. This is happening so much now around the country that there's this site you can go to, the Build Healthy Places Network. They have to have a network now because there's so many communities doing this kind of collective impact work. An example I want to end with is San Diego, which is one of my poster child for me for this type of collective impact approach. It's called Live Well San Diego, where you have a whole bunch of sectors. They actually have 150, I think, different partner organizations that are involved. But you can see examples there on the left. And they get clear on exactly what their goal is. What's the vision? What are the different 5 areas of influence that they plan to target? What are the ways they're going to measure success? And then they actually create a dashboard where they're collecting data to see how well they're doing in meeting those goals. And they're all in this together. So if you go into the office of the Chamber of Commerce there, you're going to see the Live Well San Diego chart. If you go into the various school districts there, the principals have the Live Well San Diego chart. And now that we live in the era of big data, we have the ability to use large data sets to actually track our progress in addressing each of those sectors toward the common goal. This is a picture of me in San Diego where there's this big display in the back showing the county geographic distribution around health outcomes. But the more important thing about this picture, which you can't see so well, is the people sitting there are community members, residents, neighborhood organizations sitting at tables where they have a keyboard and mouse, where they can interrogate the data sets that we have brought to them for their particular neighborhood or census tract. They can specify which variables they're interested in and basically harness the information themselves to start addressing issues of concern. That's the era that we're moving into. This is my last slide. I find this as a way of a metaphor for the importance of cross-sector collaboration. Is you can be a great oboe player, but if you get on that stage by yourself, you're not going to have beautiful music, right? So it's the orchestra, the beautiful symphony, is a product of each of those sectors, if you will, with their bringing their expertise to the table. And the conductor is sort of like a backbone organization that acts as the facilitator for convening them. But together they make the music. And that's what we're seeing now in terms of moving the needle in transforming health and well-being more broadly, is when all the different sectors in the community join hands to try to get that done. So I'll stop there. I went way over. Thank you very much.